Hello. Got some good mornings and we've got some good afternoons. It's a good afternoon. Well, 1 minute to a good afternoon here. But if you are joining us from BC, then it'd be a good morning to you. It's good something right now. Yes, Sam, it's a good something. Wherever you are in the country or outside of Canada. So we got some people joining still. Okay, so a couple things I normally mention before I get started, just on my end, is I do caution people who are new. I do have a dog, so I apologize in advance if he barks at random times. I tried to convince him to come in here for a nap today, but he was not having it. He's having a nap in the other room, so apologize if he starts barking. And apparently my neighbors have chosen today to start moving, so they're right there. So they're very, very loudly moving things into their U-Haul. So if you can hear some random banging, that's them. All right. So it's 12, so we're going to get started with the information here. So welcome, everybody. If you're new to one of these sessions, then you've never seen this slide before. If you are, you've probably seen this slide many, many times. But it is something I have to go over. So the presentation you are about to view is the intellectual property of the Department of National Defense. Any reproduction or retransmission of the slides contained in this presentation is strictly forbidden. So some of the topics discussed in this webinar may be of a sensitive nature and not appropriate for children, so we do ask for parental discretion. So today we are going to be talking about sleep disorders, specifically, focusing on adults, not children. So just keep that in mind if you do have children near you. Please understand that people's stories are theirs alone to tell, and anything that is shared by participants in this webinar, either on camera or in the chat, is not to be discussed outside of the webinar. This webinar is being recorded, however, and will be available for viewing later on capconnection.ca. Though active participation is definitely encouraged, you may simply follow along without using the chat or the video microphone functions if you prefer. So if you are new to these sessions, and I'll just let you know, I normally don't open up the mic camera functions for participants unless specifically requested at the end during question period. If you'd rather not type out a question, you'd rather ask it verbally. Only because with a huge group, you have a lot of people wanting to chat, or they forget to turn their mics on. Right, so that's the only reason we keep it off for this time being, but feel free to please engage throughout the entire session in the chat box. I have finally figured out a system where I can see the chat and see my notes and see my slides, so we are good to go. And I'm not looking at, the other side of the room, which was the problem at the beginning there. All right, so as I mentioned, today we are talking about sleep disorders, so the lowdown on sleep disorders, as part of the Sleep in You series. So if this is your first session that you're attending in the Sleep in You series, welcome. Don't worry, you're not going to be confused by any means. We kind of take a specific topic about sleep each session, and really delve into that. So you're not going to be quizzed on what was happening in the last couple of sessions, okay? Yet again, if you've been on here before, you're going to know that I'm going to ask you a poll question right away. So the first question I'm going to ask you is, what is your affiliation with the CAF community? So I'm going to share that right now. Yet again, I have a spelling mistake. I'm sorry about that. So serving member, veteran, family member, civilian employee, so a DND or CFMWS, or you are other. And I will mention that I know that there may be some civilian employees or family members that are veterans as well. So whatever best describes you at this time. I feel like some people have maybe stepped away because we're a little slower getting everybody to answer today. It's Wednesday, it's hump day. We're almost there, guys. Halfway. If you're, on the East Coast, you're more than halfway because you're almost done your day. All right, so most people have answered by this point. So we have majority are serving members, followed very closely by civilian members. We've got quite a few veterans on the line today, so welcome. That's awesome. A family member and an other as well. Perfect. So I see that some people have already said hello from wherever they're from, but if you want to in the chat, let us know where you're joining us from, either your city, your province. If you're coming from OCAN, I'd love to know kind of where people are coming from. Got Halifax, Pembroke, Alberta. We've already had Montreal and Kingston and Comox before. We've got another Kingston. Cold Lake, Alberta. Ottawa, Belgium. Welcome. Ottawa, Yellowknife. Cochrane, Alberta. Okay. Victoria, BC. Awesome. So we have quite a few different places coming today. So that's fantastic, all over Canada as well as outside of Canada. So that's awesome. So I will mention normally these sessions take about 30 minutes, but today might be just a little bit longer just because there is a lot of information about sleep disorders. I'm not going to be talking about every single one, but just in case some people have some more questions, we may go a little longer than 30 minutes. So just please be aware of that. I'm not going to be offended if you have to run away at 30 minutes though, okay? Alrighty. So sleep disorders. Can anybody write in the chat about some sleep disorders that they've heard of before? Insomnia. Night terrors, apnea, sleepwalking, sleep apnea again, anxiety, restless legs. Awesome. Yeah, so these are the ones that we're going to kind of touch on today. I'm not going to go into huge detail about every single one, but I'm going to kind of give an overview. We'll spend a little bit more time on more common ones. So we'll talk about night terrors and sleepwalking, which did come up, chronic insomnia, and what the difference is between insomnia symptoms and chronic insomnia, obstructive sleep apnea, narcolepsy, idiopathic hypersomnia, REM sleep behavior disorder, and the periodic limb movement disorder or restless leg syndrome. There are many more sleep disorders than just these ones. I'm just specifically focusing on these because these are the ones that are highlighted on the Sleep On It Canada, which is the national sleep campaign. So that's why I'm specifically looking at these ones for you guys. Okay, so let's talk about night terrors first. So when we talk about night terrors, we need to understand that they are different than nightmares. So a night terror is characterized by physical symptoms of fear. So for example, you may experience a rapid heartbeat and sweating when you have a night terror versus when you have a nightmare. It does occur usually at the beginning of the night, and it does last between 1 to 5 minutes normally. They can be longer for some, especially for younger children. So if a younger child is having a night terror, it may last longer than 5 minutes. There is, so once it is over, the individual is going to return to their regular sleep pattern and essentially be asleep, okay? So there may not be even any sign that they did experience a night terror at that point. There is no recollection of what has happened and no associated fear felt, you know, the next day. They're not going to feel that fear. They're not going to necessarily remember what has happened. They may, if they had sweat profusely during their night terror, they may feel very damp. I have actually had a night terror before, and that's essentially the only reason I kind of knew, is that I felt a little bit unsettled, but my bed was damp because I had sweated so profusely while being essentially terrified. It does occur predominantly during early childhood, but is seen in all ages. So if you've ever seen somebody have a night terror, so essentially while still asleep, an individual is going to potentially appear inconsolable, unable to answer questions that you may have. They could sit upright in bed with their eyes open. They could look fearful and panicked and essentially appear awake, which can be confusing for somebody looking at them. Acting upset, scared, confused, or agitated, struggling and acting panicky, screaming in distress or shouting, breathing fast, and their heartbeat may be very quick, and of course that sweating portion of it again. And if awoken, they could experience feelings of terror or dread. So if they are awoken from that night terror, those feelings would be there versus if they awake regularly during the next day. So when we look at what may trigger night terrors, so even though it is predominantly in younger children, adults can definitely still experience them. So these are different factors. So being overtired, experience occasional sleep loss, chronic sleep deprivation, increased stress, change in sleep routine. So whether your routine before bed or even the place that you're sleeping. So if you're traveling and sleeping in a hotel or at a friend's or family's house, that could affect it. Being sick with either, you know, the cold or the flu, starting new medications. So that's actually one of the things that happened to me is I was on a medication and it just increased night terrors apparently. And other sleep disorders have also been found to have increased likelihood of night terrors. So it is important that yes, these factors may trigger it, but the reasoning behind night terrors isn't really fully understood and they do need more research. But they have established that these factors can increase risk in both children and adults. So it's important to know that night terrors on their own really aren't an issue, aside from potential risk of accidental injury. So for adults who experience night terrors, they may experience increased fear or anxiety about having more night terrors, thereby affecting their ability to go to bed or fall asleep. Fatigue can also develop if those episodes are frequent, which could have an impact on your next day functioning. Those who experience night terrors can also disrupt other sleep. Of course, if you have a bed partner, you could definitely disrupt their sleep. Or even if you don't have a bed partner, but you have children or other people or roommates or anything in the house, they could be awoken by your night terror, especially if you're for screaming or shouting in your sleep. So that's just kind of keep in mind that in general, they're not necessarily an issue, but they could lead to accumulation of sleep deprivation because of that lack of quality. Okay, sorry, just reading a question here. Question is, what is it when a nightmare causes paralysis when you awake? Okay, could you just be a little bit more clear about what you mean there, Michael? Okay, I'll move on as you kind of explain a little bit more about that. It might be answered in some other slides. There is sleep paralysis, which I will mention on one of the other sleep disorders. Okay, so sleepwalking. So sleepwalkers generally perform routine behaviors in a calm manner while being asleep. So you may have sleepwalked yourself when you were little, or you do right now, or you've seen somebody sleepwalk. One of my sisters, when she was little, she sleptwalked all the time, which I was also a child, so it was very strange to wake up and she was randomly like doing behaviors in my room because we shared a room when we were really small. They do rarely remember the episodes, and if they do, they can only recall parts of those episodes. Those episodes are usually short, although some can be longer than 30 minutes, and they do typically occur early in the night during the first deep sleep stage. So it is more common in childhood, and the episodes do peak around 10 years old. And it's been found that only 2 to 5% of adults are affected by sleepwalking, and as it generally starts in childhood. So adult onset sleepwalking is associated with medications and neurodegenerative diseases, or it is confused with REM sleep behavior disorder. It's not as common for it to happen in adulthood, more that you were a child and it just kind of, you sleepwalked as a child and it just continued as an adult. Most people do grow out of it though. When we look at what causes sleepwalking episodes, it's very similar to what causes night terrors. It's anything that really can increase the normal amount of deep sleep or create arousals, especially during deep sleep. So your sleep deprivation, your occasional sleep loss or chronic sleep deprivation, or being overtired, irregular sleep schedules, increased stress, that change in sleep routine. If you're sleeping in a noisy environment, if you're sick, if you consume alcohol during the evening or close to bedtime can also increase that risk. Exercising close to bedtime or other sleep disorders. So again, like night terrors, sleepwalking episodes are usually very benign. However, there is potential risk for accidental injury, especially as an adult who is able to open doors. You can see how that could increase risk if you're leaving your bedroom environment, but also your house environment. If episodes are frequent, fatigue and sleepiness can definitely develop. Okay, just going to go back to this chat quickly because there is a quick question. Okay, yeah, so somebody has mentioned, I've been able to have a full conversation with a person I knew who sleepwalked. It was weird. Yeah, so for somebody who's watching somebody who is sleepwalking, it is very strange because it seems like they're very with it, but they're asleep the whole time. So it's a very strange, but also very interesting thing to see. And Michael, I think you've just clarified potentially. So when you think you're awake but still asleep and you're trying to wake from a nightmare of being watched and touched and then wake when someone helps you, it feels really real. Yeah, so nightmares generally, so dreams overall, the more vivid ones happen during REM sleep. And when you are in REM sleep, your muscles are immobile, so you're unable to move. So when I was talking about sleep stages on the first session, I mentioned that when you have those feelings as though you cannot move, you're more likely in REM stage and you actually physically can't move. So it's really disconcerting when you're having an uncomfortable dream or a nightmare where you need to move because you need to run or you need to move away from something, but you're unable to, you don't physically feel like you can. So that might explain it. There's also sleep paralysis that can come with certain sleep disorders as well, for sure. So it really depends on if it's, you know, an occasional thing that happens with nightmares, or if it's something that's happening quite frequently. If that's the case, then it's something that you might want to be talking to your healthcare practitioner about. Okay, moving on to chronic insomnia. So it's actually the first one that somebody mentioned on here. And that is interesting because chronic insomnia is the most common sleep disorder. So at least 1 in 4 people experience insomnia symptoms occasionally, and as many as 1 in 10 people suffer from chronic insomnia. So you'll see that it's different from suffering occasionally to being chronic. So it's essentially mentioned as dissatisfaction with sleep quality and duration despite adequate opportunity and circumstances for sleep. So periods of acute insomnia are common because they often result as a transition during our lifespan. Situational insomnia is considered normal. So for example, you know, let's say when COVID-19 started and everybody was really, I mean, things are still very up in the air right now, but more so in March, we really didn't know what was going on at all. There is potential that some people were experiencing insomnia like symptoms because it was a stressful situation. When it's a dissatisfaction with your sleep quality and duration, that is when it becomes a chronic insomnia, because you despite sleeping enough or trying to sleep enough, you're still not able to get that sleep quality and that duration that you want. It does cause significant distress because it is a long-lasting problem. It is a 24-hour problem that impacts both day and nighttime functioning. So people a lot of times think insomnia is just a night issue, and it's not, because it definitely affects your daytime functioning. Aside from sleep discontentment, people report 1 or more nocturnal insomnia symptoms. So these are the nocturnal insomnia symptoms here. Trouble falling asleep. So that's called your initial insomnia or sleep onset insomnia, where you toss and turn for more than 30 minutes. Trouble staying asleep at night, which is your middle insomnia or sleep maintenance insomnia, is waking up several times during the night and or having trouble falling back asleep after you do wake up. And then waking up too early in the morning, which is your late insomnia or sleep offset insomnia, which is being unable to go back to sleep. So occasional nocturnal symptoms often occur when we're stressed, under pressure, grieving, or coping with a change in our lives. And if that is the case for you, then you don't have to really be worrying right now. If you are in an insomnia pattern that lasts and it's hard to break, there are things that you can do about it. But the first step would be to talk to your healthcare provider to determine the cause of your insomnia symptoms. For those who do have a diagnosed chronic insomnia, the treatment that's been shown to have a really, really good rate of success and long-lasting effects is CBTI, which is cognitive behavioral therapy for insomnia. There are apps and things you can do for that, but I would really recommend you talk to a healthcare provider or mental health. I know at Four Wing, when everything's, you know, normal functioning, they actually run an insomnia group, and they do CBTI stuff on there. And people, I've heard people have gone to it and they've loved it. They found it really, really helped them. So if that's an option for you guys, for sure, take a look at that. We do want to remember that insomnia symptoms do have significant immediate and long-term health consequences. So they are responsible for fatigue, lower energy, lack of concentration, mood swings, and increased risk of accidents and injury. When we have those cumulative effects of sleep deprivation and insomnia, we do have long-term health consequences, including increased risk of hypertension, obesity, and depression. So we do need to keep that in mind. That's really important to you know, talk to somebody about it if we're experiencing these symptoms. When we look at insomnia, it's what's called the 3 Ps model. These are kind of the reasons behind it, essentially. It's not fully understood, again, like most sleep disorders, but it appears that the brain's overactive before we're going to bed. So essentially, we have a hyper-aroused brain. So the symptoms are always related to the same individual factors, which have been categorized in this 3 Ps model. So your predisposing factors are those that put the person at risk. So examples would be your biological, your sex, your age, or your psychological traits, which would, let's say you have an anxiety-prone personality. And then precipitating factors are those that trigger the symptoms. So examples would be stressful life events, medical illness, or depression, anxiety. And perpetuating factors are those that maintain the symptoms and contribute to them being chronic. So examples would be poor sleep habits. So let's say you spend an excessive time in bed, or you have sleep hygiene issues. So you take your electronics to bed, or you don't have a sleep routine before going to bed, or napping as well can affect it. I'm just going to take a quick look over at the chat here. Okay, so some people are asking about waking up multiple times a night. So if you're waking up multiple times a night and you're aware of those times, because it's normal actually to have about 10 arousals per hour, but we don't remember those. It's different if you're actually waking up for a few minutes or longer, and you're remembering all of those instances, or you're waking up and you're having difficulty going back to sleep. If that's the case, then I would definitely be talking to somebody about that. So somebody's also mentioning that they use sleep medication for sleep. So that is definitely a treatment that's been used for sleep disorders. However, many healthcare practitioners will try not to have somebody become, needing the sleep medication. Preferably that you try something. So for example, if you have insomnia, trying CBTI with maybe a sleep medication with the hope that you would, be able to not have that sleep medication. But that's an individual need. And something you definitely want to talk to a healthcare practitioner about. We don't want to self-medicate, so don't go to the store and go grab a sleep medication and then become, like you need that one versus having a healthcare practitioner talk to you about that. Somebody else is also mentioning PTSD. So yes, PTSD is definitely an issue when it comes to sleep disorders, especially insomnia. PTSD, of course, can also lead to a fear of going to bed because you may be more prone to nightmares or night terrors. So definitely PTSD has been found to definitely have a link to sleep disorders for sure. Somebody also, so dementia, one of the long-term effects as well. Yeah, so it's been shown that insomnia has some effects on cognitive memory as a sleep deprivation overall. So yes, if you're chronically sleep deprived and insomnia does cause sleep deprivation, then yes, you could have cognitive effects such as dementia in the long run, or may increase your risk, essentially. Okay. Obstructive sleep apnea. So a few people did mention sleep apnea when I asked about some sleep disorders. So there are several types of sleep apnea. The most common or most well-known ones are going to be your obstructive sleep apnea and your central sleep apnea. Obstructive sleep apnea is the most common out of all of them. And it is the one that I'm going to focus on today because, when we talk to most people, when they're talking about sleep apnea, they're talking about obstructive. Yet again, please don't diagnose yourself with this. You do want to go through a healthcare provider and potentially a sleep clinic to also make sure that you have a proper diagnosis. So what is sleep apnea? So it's an individual involuntarily, while sleeping, stop breathing, or their breathing becomes obstructed for several seconds at a time. So essentially, when the individual tries to breathe, the air is not passing or it passes with difficulty. So the muscles in the back of the throat fail to keep the airway open. So essentially, as you fall asleep, your muscles are going to relax throughout your body, including your upper airway muscles. For those who have OSA, their muscles lose too much of their muscle tone, which causes the upper airways to either fully or partially collapse repeatedly while they sleep. So once the obstruction or closure of the airway occurs, the insufficient air flows in and oxygen levels are reduced in the lung and cells. And essentially that triggers an emergency signal to restore those oxygen levels. So that leads to reestablishing muscle tone, allowing the airways to open and proper breathing to start. Emergency reaction can create a brief awakening called a microarousal, which most sleepers are unaware of. And sleepers are also generally aware of that they lack air due to their apneas. So it is the most common respiratory sleep disorder affecting all ages. It is a myth that only men and or obese individuals suffer from OSA. I think that's a very common misconception that unless you're a male and especially unless you're an obese male, then you're not going to get OSA, and that's not the case. However, they have found that the older that you get, if you're pregnant, if you have a small jaw or chin, or if you are overweight, you do increase your risk of having sleep apnea. So those are things to kind of keep in mind, but it can affect anybody. Okay, so when we look at obstructive sleep apnea symptoms, there are symptoms during sleep, and there are symptoms during the day. Okay, so the sleep symptoms are apneas, which I just mentioned. Those are the obstructed or interrupted breathing repeatedly for several seconds. These are actually very rarely self-reported. Okay, you have your snoring or whistling, which can happen. bed partner complaints or worry. So oftentimes your bed partner is the person that's saying you have an issue because they're going to be woken up by your snoring or your breathing interruptions. They may also just put themselves into another room to go to bed because you're disrupting their sleep so much. So if your bed partner is complaining about it or mentioning it, please take it seriously because there's reason they're telling you. I hope they're not making it up. I feel like they're probably not. Short awakenings or arousal. Oh, sorry, I didn't mention the choking, gasping thing. Frequent need to urinate and night sweating as well. Rare symptoms could include agitated sleep, nightmares, insomnia symptoms, or bedwetting. When we look at daytime or diurnal symptoms, you have excessive sleepiness, which is the urge or need which is difficult to repress to sleep during the day. Unrefreshing sleep, fatigue, which is an overall lack of energy, trouble concentrating, decline in energy, your cognitive symptoms are going to decline, morning headaches, dry mouth upon awakening, and irritability and mood changes. Rare symptoms would include acid reflux, heartburn, erectile dysfunction, and or low sex drive. Okay. Once I'm done with the sleep apnea portion, I'll just go over and check that chat box there. So we look at furthermore, contributing factors include individual anatomy and lifestyle habits. I mentioned that small jaw and chin structure, as well as your body weight, your age, your abnormal, or if you have abnormal airways. Your lifestyle habits, of course, can impact that as well. If you have larger than average tonsil and or adenoids, if you have a larger neck circumference, those can also increase your risk. But they're not the be end and all. Lifestyle habits can definitely increase your risk too, okay? It can have severe consequences on your daily life, safety, and health. OSA, it doesn't just affect sleep, it affects your oxygen input, so it definitely can have severe consequences. So if left undetected and untreated, it can have irreversible consequences. So that it can include cognitive decline, heart disease, diabetes, or stroke and motor accidents. Most night and daytime symptoms will be quickly relieved when OSA is treated properly. So we do want to talk to your healthcare practitioner about this because there are effective treatments and solutions. For a diagnosis, there's a combination of subjective and objective sleep assessments, either done at home or at a sleep clinic. And there's different treatments, but the most common would be your continuous positive airway pressure device or your CPAP machine, which you'll see the individual is wearing in this picture. Also oral breathing devices or other appliances such as nasal dilators or a mouth guard. You may also have positional therapy, surgical treatment for airway anomalies, or potential weight management if that's potentially causing it. Okay, I'm just going to check the chat quickly here. So Michael, I'm thinking that the question you have is related to OSA. Is it something that can be treated to see improvement for OSA? Yeah, so it definitely can be treated. You may require a CPAP machine, for the remainder, for sure. But that can, just wearing the CPAP machine will definitely assist you in sleeping and your oxygen supply. So you'll take a little bit to get used to a CPAP machine, right? But it is definitely worthwhile, and eventually it's just kind of going to be something that you're just so used to putting on or wearing. Madeline, you mentioned, yeah, it gets easier sleep hygiene, 2-hour routine before bed. That's fantastic. Awesome. Okay, yeah, and breathing techniques and a routine helps. Yeah, so those are some things we're going to be mentioning on the last session, which we keep calm and sleep on, about what we can do to really increase our sleep hygiene. Yeah, awesome. Yeah, if your husband has started a bedtime routine, made a huge difference. Fantastic, great. And for people who are OSA, I really, really want to push home, take your bed partner complaint seriously. I've been on a vacation with somebody before, and I'm very snoring. I can't sleep with snoring at all. So there was an individual with me in the same room, and the individual was snoring, and I said, you snore a lot, like just letting you know. And his wife at the time said, I've been telling you. He's like, no, it's fine. And I said, no, it's abnormal. Like, it's not normal snoring. It's definitely like you're not breathing. And he's like, no, it's fine. I said, I would highly recommend that you want to check that out. But yet again, just wanted to play that off, right? So take heed to somebody who's mentioning that maybe it's an issue. Okay, narcolepsy. So when we look at narcolepsy, narco means to put to sleep, and lepsy means a seizure or attack. So The typical symptoms when we look at narcolepsy, these are the 5 main symptoms, which can show up in diverse forms and variable intensities. So all people with narcolepsy have disabling and severe daytime sleepiness that presents as a sleep attack, which is a need to sleep that you cannot control. People can fall asleep during various activities, and aside from these sleep attacks, the remainder of daytime functioning is at a normal level of alertness. You could also have cataplexy. So that is experienced by all those who are affected by type 1 narcolepsy. So essentially there's 2 types. There's narcolepsy with cataplexy, and there's narcolepsy. Okay. So cataplexy is a sudden loss of muscle tone while being awake, which can last a few seconds to several minutes and does go away on its own. It can affect all muscles or just parts of your muscles. And during a full attack, a total body collapse occurs, followed by temporary paralysis while the person remains fully awake and conscious. So you can see how terrifying that would be. It is actually brought on by strong emotions, often being positive ones. So people, when they laugh or they're excited, it can actually trigger cataplexy. Sleep paralysis and hallucinations at sleep onset or offset are often the most unsettling symptoms that come with narcolepsy. They do occur during the transition of wake and sleep. Sleep paralysis is the temporary inability to move or speak for a few seconds or minutes while being fully conscious, and it does occur at the edge of sleep without an emotional trigger, so it's different from cataplexy. And some people can experience hallucinations, which are often visual or dreamlike images and occur upon falling asleep or awakening from sleep. And of course, poor sleep quality because of the interrupted sleep that you're going to be getting. About 1 in 2,000 people are affected. So this is not as a common of a disorder, but we've probably heard about it quite often. Symptoms do often begin in adolescence or mid-adulthood. There is a very strong likelihood that this is under or misdiagnosed because health professionals just really aren't well versed in the disorder, nor is the general public. It's often confused with other sleep disorders, and people do suffer from social stigma from narcolepsy because they're viewed as lazy, sleep deprived, or having memory problems, which is really unfortunate because they may not be going to get the help they need because of that stigma. It can take as long as 10 to 15 years to get a proper diagnosis, leading to many to be diagnosed in either the 30s or 40s. So even though those symptoms are starting in adolescence potentially, they're not being diagnosed till much later in life. It does significantly impair, although lifelong disorder does not generally worsen over time, but it has been found to significantly impair one's quality of life. So we have to realize that people are falling asleep during activities unwillingly, or if they have a cataplexy episode, they might be terrified of laughing, right? So that's a huge issue with their quality of life. The causes of narcolepsy really aren't fully understood, yet the culprit does seem to be a combination of genetics and brain chemistry. And symptoms of narcolepsy can be controlled, so that's really important to remember as well. Initial non-pharmacological treatment includes specific measures of sleep hygiene. Daytime sleepiness is often treated with medication that can stimulate alertness, and antidepressants are often used to treat cataplexy, hallucinations, and sleep paralysis. So how to be diagnosed is essentially through symptom recognition, awareness, and sleep studies. That'll allow for that proper diagnosis and treatment. Okay. Is there a difference between fatigue or sleep attacks? I sleep different times when I'm so tired. So fatigue is really an overall lack of energy. Sleepiness is a really strong urge to sleep that you cannot repress. And then a sleep attack is essentially you fall asleep without being able to control it whatsoever. So that would essentially be the difference, is if you're tired throughout the day, you really don't have the energy, that would be fatigue. If you really just need to go lay down, but you are able to get to, a bed or a place to lay down and fall asleep, that would be a sleepiness. And then a sleep attack wouldn't matter what you're doing, you're going to fall asleep. Okay. Hypersomnia is the next one that we're going to mention here. So the hallmark feature is excessive daytime sleepiness, which is chronic and not linked to sleep duration. So essentially, it is persistent sleepiness despite you sleeping that 7 to 9 hours at night, or you have naps as well. You have at least 7 to 9 hours within 24 hours and you are still excessively tired. Aside from daytime sleepiness, you can also have other symptoms such as not feeling refreshed upon awakening, excessive need for sleep with unrefreshing sleep despite adequate or long sleep time, disrupted or lack of attention, chronic headaches, excessive sweating, and depression. Okay. The excessive need for sleep is if you sleep essentially they're sleeping 9+ hours during a 24-hour period, frequently, including long nights. So they're sleeping 9+ hours at night with long naps, which are one or more hours, and they're still not feeling refreshed, or they're still having that severe sleepiness. Okay, which is important to realize, because it's different than just being tired. Okay. Others also going to potentially experience automatic behaviors involving very brief daytime sleep episodes while performing habitual activity like driving, which is, you can see how dangerous that could be. And some people do move or they talk a lot to counteract their need to be asleep and to fight that attention deficit. The onset tends to be in adolescence or early adulthood. It is a rare condition. So the estimates do indicate between 0.02 to 0.1% of the population is affected, and there is no sex difference. So men and women, same kind of risk involved with that. The diagnosis again with this is going to be made years later from adolescence or early adulthood, because of that lack of awareness, the self-blaming on yourself, and as well as that social stigma, because people are going to see that think that you're lazy. Lifelong symptoms may vary in intensity as well. And those causes, essentially, when all potential causes of severe sleepiness have been ruled out, it's called idiopathic hypersomnia. In other cases, it could be attributed to another sleep disorder, an ongoing health conditions such as depression or hormonal changes. So, example, pregnancy or thyroid dysfunction. It can also be a side effect of a drug treatment or the consequence of head trauma. However, please keep in mind it is very understudied and further investigation is needed. So to be diagnosed with this, yet again, symptom recognition, awareness of hypersomnia, and sleep studies. Okay. Healthy lifestyle choices are often used to curtail the daytime sleepiness, such as eating well and exercising regularly. Okay, REM sleep behavior disorder, RBD. So I apologize, we are going over the 12:30. I did mention that we probably would do that. If you do need to head out for any reason, I will not be offended by any means, okay? So move to act out what's happening in their dreams. So people with RBD have a defect in their brain, which leads them to lack the protective lock that we normally have that prevents us from moving during REM sleep. So remember I said during REM sleep, we don't move. These people actually lack that ability. So they are moving during their REM sleep. It could include moving their entire body. They could be laughing, talking, walking, kicking and punching, sitting up in bed, getting out of bed, all while being asleep or dreaming. Okay. Behaviors are usually in line with what the dreams are. So that would mean that they are illogical, they are a distorted form of reality, and they are emotionally charged. So they do often mirror typical dream content. Package has arrived, apparently. Mirror typical dream content, such as being chased, aggression, feeling threatened, or potentially a sexual experience. Vigorous or violent behavior does occur occasionally, or very often, depending on the individual, once or several times a night. Sorry about that. It usually does occur in the second half of the night, closer to awakening, because the REM stages are longer at that time. And it is a rare condition, so it does affect less than 1% of the population. And it is predominantly in men over the age of 50. Okay, so anyone could get it, but predominantly the men over the age of 50 would be the ones with RBD. Onset is gradual and it does worsen with aging. So unlike narcolepsy, this condition actually does worsen as you age. Diagnosis is based on sleep studies, a medical exam, medication review, and bed partner report. It is a neurological disorder, so it is usually treated successfully. However, it can be an early indicator of Parkinson's disease, which is a neurodegenerative disease. So like many sleep disorders, they're still trying to figure out the exact mechanisms behind RBD. However, recent evidence has pointed out that there's a dysfunction in the part of the brainstem that is involved with the REM sleep muscle paralysis mechanisms. And it can occur in conjunction with neurodegenerative disorders such as other neurological disorders such as epilepsy or multiple sclerosis, or other sleep disorders, and with medications. So there's a few different things that could definitely increase that risk of those. And the last one here is we're just going to make a comparison between the periodic leg or limb movement disorder and restless leg syndrome. So when we look at these two, they are very different disorders, but they're often confused with each other because they have many, they often do present together and they do share certain resemblances. So for example, they both affect the limbs, predominantly the legs. They can start at any age, but more often over the age of 50. They can be linked to iron and ferritin deficiencies. The symptoms may disrupt sleep, and they are treated similarly. However, let's look at the differences. So the main symptoms when we look at periodic leg or limb movement disorder is involuntary movements during sleep of the limbs, specifically the legs. Movements are repetitive and periodic, and they are often described as twitching, kicking, jerking, or an upward flexing of the feet. And about 50% of those who have PLMD also have RLS. Okay, those periodic movements generally don't wake people, but bed partners could be disturbed by it. People also have reported difficulty falling asleep and staying asleep because of this disorder. When we look at RLS, or restless leg syndrome, you have unpleasant and uncomfortable restless feeling that is hard to describe for people. People have mentioned as kind of like a crawling of the skin, or just a really discomforting sensation. It includes also the irresistible urge to move the legs and sometimes the arms. Voluntarily movement can relieve these sensations. So if you do give in to that urge, then it could relieve those sensations. And about 80 to 90% of people who have RLS also have PLMD. Okay. So when we look at when it's going to occur, PLMD can occur when falling asleep and while asleep before REM sleep occurs. So when we look at RLS, it can occur while at rest or falling asleep, after sitting or laying down for an extended period, and it does occur more frequently and worsen in the evening or at night. Okay. Overall, women are more affected by RLS than men, and pregnant women are very often affected as well. Both disorders are either idiopathic, so that's that without a known cause, or they're secondary to a medical condition or related to medication or drug use. Idiopathic, so without a known cause, disorders often runs in families. Many people will experience both disorders, symptoms of both disorders on a regular basis without a major impact on their quality of life. If it's starting to impact your quality of life, that's a different story. So if you're experiencing frequent or severe symptoms, then you do want to discuss those with your healthcare practitioner. A diagnosis of these are generally made with a medical exam, a lifestyle assessment. There is a blood test that normally includes your ferritin or your iron levels, so that you're determining your iron deficiency, and sleep studies as well. And treatment does focus on symptom management with lifestyle and behavioral changes and medication. Okay. So that's it for the information on the sleep disorders. If you do want to know more about sleep disorders, I have highlighted a few places. So Canada's Sleep Campaign, the sleeponitcanada.ca, they actually have a whole area on sleep disorders, and you can really go into depth on each of these ones that I have covered. Canadian Sleep Society, they have patient brochures for specific disorders, so you can take a look at those as well. I have included Wake Up Narcolepsy, which is a narcolepsy foundation. I actually was able to talk to the individuals there when I attended the World Sleep Congress, and really great people that were really knowledgeable. There was actually people who had been diagnosed with narcolepsy that I was able to speak to. The Restless Leg Syndrome Foundation and Sleep Well Nova Scotia specifically talks about insomnia and has an overview of what CBTI is if you're interested in learning more about that. They also have a sleep hygiene checklist that you could fill out and bring to your healthcare practitioner if you're concerned about a sleep disorder. Okay. And yet again, the Sleep in You series, we have the next 4 sessions going up as well. I'm going to put out the next polls. I just have 2 questions to finish up with. So I do want to ask you if you feel like what you learned today you can apply in your daily living. So that's going to be the first question I'm going to share right now. If you could answer that. Please remember, I don't know who answered what, so you're safe here. It's anonymous. So you can answer strongly disagree, disagree, neither agree nor disagree, agree, or strongly agree. Okay, most people have answered here. All right. And the next question is, how satisfied are you with the Demio platform? So this is the platform that we use to come to you virtually. So extremely dissatisfied, somewhat dissatisfied, neither satisfied nor dissatisfied, somewhat satisfied, or extremely satisfied. So you can answer that one. And at this time. If you do have any questions, I am going to open that up to you. So if you have any questions, let me know. If you want to ask it verbally, let me know and I can turn on your mic. And here are those resources that we share as well at the end of every session, in case you need some assistance with anything as well. You're welcome. If there are no questions, I will say thank you very much for coming today. No, so the next session is not on Monday. Somebody's asking me that. No, I am not showing up on Victoria Day. Sorry about that. So the next session is actually going to be next Wednesday, so we're going to skip Monday. So it'll be on May 20th, which will be how booze can hinder your snooze, so all about alcohol and sleep. And then we'll be going back the following week on the Monday, Wednesday, and then the last session will be Monday, June 1st. Okay, Jerry. So thanks for letting me know that you missed the first part there. So my name is Lisa. I'm the health promotion specialist at 4 Wing Cold Lake. Okay, so you're welcome. So if there are no other questions, I really appreciate you, joining us today. For those people that are still here, I'm actually just going to go grab that next link for the next session, because I normally put that in there. And normally I have it all ready for you, but I'm a little slower today. Sorry about that. The question is, if you miss a session, can we see it later? Yeah, so the plan is for those sessions to be available on a YouTube channel eventually. But right now, actually, if you go to, we've put links to the previous sessions on our page. I'll just grab that link for you as well, Joanne. So if you want to just hang out on there for just a minute, I can grab that link for you. And it's not just these sessions, it's all the sessions that are done nationally as well. So, okay, here's the registration link for next Wednesday's session if you're interested. And then just give me 1 second and I'll grab the link for the where we link the previous sessions. Okay, so this is linking all the past sessions, the recordings. I will say that it takes about a week or so to see this week. So this week's sessions from Monday to Friday won't be up until probably mid to end next week at the earliest. So just kind of keep that in mind if you're looking for something that is scheduled for this week. Otherwise, we will see you next week, hopefully, everybody. Thank you for joining today. I hope that you have a great day and your weather's good. We're supposed to get up to 14 and sunny today, so I am happy, and I'm going to go do some lawn work after work. So thank you for joining. Enjoy the rest of your day.